Welcome to this clinical walkthrough on the overactive bladder case for UKMLA, brought to you by Mediate, your 24/7 practice partner.
Right, so today we're going to break down this really common GP scenario into 5 key parts. This will give you a super clear structure to follow in your exam. We'll kick things off with mastering the history, then we'll walk through the examination, how to explain the diagnosis, creating a solid management plan, and of course how to wrap it all up safely.
Okay, so your station begins. An 80-year-old man comes in and says this. Now, the key things jumping out here are that urgency, that sudden, desperate need to go, and the fact he's had an episode of incontinence. Our job is to take the statement and really unpack it, piece by piece, to build our case.
All right, first things first, let's master the history. Honestly, in the UKMLA, this is where you can score a ton of points just by showing you have a logical and really thorough way of getting the information you need.
A brilliant framework to use right off the bat is ODI-PRA. It just keeps you on track. Onset, duration, intensity, progression, aggravating and relieving factors, and then associated symptoms. Now, when you get to associated symptoms, this is where you need to dig a little deeper. Are you asking about things like hesitancy, a weak stream, or if he's getting up at night to pee? That's nocturia. These details are what will help you start to figure out if this is OAB or something else, like an enlarged prostate.
Okay, once you've got the story of the main complaint, you need to pivot. Now we're hunting for differentials, and, super importantly, red flags. You've got to ask specifically about bladder irritants, things like coffee, alcohol, that sort of stuff. And then, it's absolutely vital to screen for red flags. Is there any blood in the urine or hematuria? Any pain? These could point to something more serious like a UTI, stones, or even a malignancy.
And to make sure you're not missing any big systemic issues, the PLAB mnemonic is your best friend. It's quick, it's effective, and it covers all your bases. We're talking fever, loss of appetite, anemia symptoms, weight loss, and sweats. A yes to any of these should definitely make you think about more serious underlying problems.
Next up, we're diving into the social and medical history. Now, in this case, pay close attention to his medications. He's on an ACE inhibitor, ramipril, and a calcium channel blocker, amlodipine. Your brain should immediately be thinking, could these be contributing? Because they definitely can. And of course, don't forget to ask about any family history of urological cancers.
Now, for what I think is one of the most important parts of any consultation, the patient's perspective. Using the ICE framework, ideas, concerns, and expectations is key. This is so much more than just a box-ticking exercise. It's how you build rapport. You can see his main concern here is simple. Why is this happening? If you can address that worry head-on, you're practicing excellent patient-centered care, and that's where the high marks are.
Okay, history's done. Let's move on to the physical examination. This is where we gather more clues to build our clinical picture, confirm what we're thinking, and start ruling out some of those other important diagnoses.
You'll want to clearly signpost these 4 steps to both the patient and the examiner. So you'll check for a palpable bladder to make sure there's no retention. You'll perform a digital rectal examination or a DRE to feel the prostate. And of course, a urine dipstick is a non-negotiable bedside test to look for infection.
And look at this. The findings in this case are pretty classic for an uncomplicated OAB. Normal OBS, no palpable bladder, a smooth prostate, and a clear urine dip. What does all that tell us? Well, it pushes us away from things like infection, major BPH, or urinary retention. Every normal finding here just makes our working diagnosis of OAB that much stronger.
Now, even though we're feeling pretty confident about OAB, you absolutely must mention these baseline investigations. It shows the examiner you're being thorough and safe. You're checking for things like anemia, any kidney problems, or maybe undiagnosed diabetes. And a post-void bladder scan is also a really great idea to definitively rule out any incomplete bladder emptying.
All right, this next part is a big moment in the consultation, explaining the diagnosis. Your ability to take a complex condition and explain it with clarity and empathy is a huge skill, and it's definitely being tested here. So what exactly is overactive bladder? Well, at its very core, it's a problem with the bladder muscle squeezing when it shouldn't be. The number one symptom, the thing that defines it, is that sudden gotta-go-right-now feeling, which we call urgency.
And this slide is gold. It shows you how to do the magic trick, translating that complex clinical jargon into language your patient can actually understand. So while we're thinking detrusor muscle overactivity, we can say to him, your bladder has become a bit more sensitive, a bit twitchy. That simple analogy is perfect. It helps him get what's going on, and it directly answers his main concern from earlier. Why is this happening to me?
Okay, on to the management plan. The key word here is collaborative. This isn't about you just telling him what to do. It needs to be structured, practical, and something you both agree on.
So according to the guidelines, the first line of attack is always conservative measures. You need to walk him through each of these steps. Now, the trickiest one to explain is often about maintaining good hydration. So many patients think, well, I'll just drink less. But you have to explain that this actually makes things worse because their urine gets more concentrated and just irritates the bladder even more.
You know, getting that explanation just right and doing it confidently is a real skill, and it's something that only comes with practice. If you want to perfect that delivery and run through the full scenario, you can practice this exact case right now and get objective feedback on mymediate.com.
It's also really important to show the examiner that you're thinking one step ahead. So you should mention that if these initial strategies don't quite do the trick, after a good trial, say 4 to 6 weeks, then we have other options we can discuss, like starting a medication.
And finally, we need to close the consultation safely. You can't just end it there. This means giving crystal clear safety netting advice and setting up a concrete follow-up plan. This is how you demonstrate that you're a safe and responsible doctor. And your safety netting has to be specific. Don't just say, come back if things get worse. That's too vague. Use the same red flags you screened for earlier to give him explicit reasons to seek an urgent review. This empowers him and keeps him safe.
And laying out a timeline like this is perfect. It gives the patient so much clarity and reassurance. It shows them that there's a structured plan in place and that you're going to be monitoring his progress every step of the way.
So, as we wrap up, here's a final thought to take with you. While telling patients to cut back on irritants is vital, probably the biggest challenge is convincing them to keep drinking enough water when they're terrified of having an accident. Nailing that conversation and helping them find that delicate balance, that's the real art of it.
This walkthrough has given you a really solid structure and the key knowledge to absolutely ace this station. But remember, confidence comes from practice, and you can practice this exact case now on mymediate.com.